Hello, I'm Dr. Kimberly Biting. I'm a geriatrician at Vanderbilt University Medical Center. Today I'm presenting on COVID-19 management in skilled nursing and assisted living facilities. This is part of a series given by the Mid-South Project ECHO. By the end of the presentation today, you should be able to list 2 reasons why skilled nursing and assisted living facility residents with dementia have increased risk of getting COVID-19. Name at least 2 strategies to limit the spread of COVID-19 within a facility, and cite the importance of employee COVID-19 vaccination in limiting the spread of COVID-19 within a facility. Why are residents in skilled nursing and assisted living facilities at a higher risk of getting COVID-19? There are a few reasons. There are certain risk factors in the special population that make COVID-19 more likely to spread and also be more harmful. Residents living close together in areas like skilled nursing facilities and assisted living facilities can't socially distance. They often share spaces like gyms, dining halls, and recreation rooms. They also require assistance from others in activities of daily living and independent activities of daily living, which require close contact. Patients with cognitive impairment or those living with dementia or dementia-related illnesses may have difficulty remembering to keep a mask on, and certain residents with respiratory conditions may have difficulty keeping a mask on. In this population, there's also an atypical presentation of COVID-19, which may make it more difficult to pick up on the classic symptoms of COVID-19 and identify early and treat. The illness may not be recognized until the resident is very ill. And often, many of these residents have many medical problems, and so an infection from COVID-19 might be more impactful or cause more severe illness. Should facilities still be screening for COVID-19? It's a great question. While the guidelines are updated regularly by the CDC, what we know is that screening is often variable among facilities. Screening according to CDC guidelines depends on community levels of COVID-19 as well as facility vaccination rates. Please check the CDC for more guidelines on your specific region and what screening regularity your facility should be pursuing. Screening should always include staff, residents, and visitors. And there are multiple types of screening for COVID-19. This includes COVID-19 symptom screening, which often occurs at check-in at the beginning of the day, or rapid COVID testing with a swab. Testing, which is diagnostic, should be pursued if somebody develops COVID-19 symptoms. In addition to the typical COVID-19 symptoms that we think about with this illness, like cough, congestion, sore throat, headache, muscle aches, loss of smell and or taste. Older adults and those living in assisted living and skilled nursing facilities may have sudden refusal to eat, or elevated but low-grade temperatures above 99 degrees Fahrenheit. And some residents may not develop a fever at all with COVID-19. Some other more atypical symptoms of COVID-19 that we see in an older population include acute mental status changes like confusion or delirium, which is hyperactivity or hypoactivity, or a sudden change in their functional ability. So all of a sudden, somebody who used to be able to maintain their activities of daily living needs total assistance for ADLs and ambulation. That might be a trigger to think about testing for COVID-19. Diagnosis of COVID-19 depends on testing. If a resident in the facility has COVID symptoms, but a negative rapid test, they should have a COVID-19 PCR test to confirm. Rapid tests have more false negatives than false positives, and rapid tests often have false negatives in the first few days of illness onset because they require a high viral load and antigen load to test positive. If a resident or a staff member has a positive rapid COVID test, they should have a PCR test to confirm diagnosis, but the positive rapid COVID test should be assumed to be a positive COVID test. The first step in a positive COVID-19 diagnosis is to isolate the individual who has tested positive. Often, facilities dedicate a unit with restricted access for those with a COVID-19 infection. Standard protocols for a restricted unit include not going in and out of the unit on the same day, and each individual should have private rooms. These units should have dedicated staff who only work in that area to limit spread to the other parts of the facility. Nurses, CNAs, therapy staff, and housekeeping should all be dedicated to that area. They should not work in other facilities while working on a COVID-19 unit to limit potential spread between nursing facilities or assisted living facilities. Staff communication with others outside of the unit should utilize multiple types of communication, like landline phone, bell, tablet, or iPad. Staff working on COVID-19 units may feel like you're on a deserted island. And so take time to care for yourself and connect with people after the end of your day to take care of yourself as well. For residents on the isolated unit, unfortunately, no visitors should be allowed due to the risk of spread to visitors and the community. Communication with families should be encouraged, as we know that's important for cognitive health as well as social health of these individuals. Utilize tablets or iPads, window visits, to help loved ones connect with their family members. And please consider doing daily updates to families. This is a very stressful time if their loved one is ill. Even consider dedicating a staff member in the facility to notify families of patients with COVID infections about new diagnosis, updates, and disease process. Families do really appreciate that. Residents may develop delirium, which is an acute confusion or change in their mental status. This happens with many different illnesses, but especially COVID-19 in older adults. Even patients with mild COVID-19 symptoms can get this delirium. The most important thing is to reorient and redirect the individual when they're agitated or confused. Remind them who they are, where they are, and settle them down. This works a lot better than any sort of medication would. Delirium can also be precipitated by discomfort. Things like pain, dehydration, low oxygen status, constipation, or urinary retention. Please search out for something like this that could be triggering the delirium and treat it if it is contributing. Personal protective equipment is incredibly important as part of the isolation and care protocols in COVID-19 units. Personal protective equipment includes gown, gloves, face shield, and an N95 mask that has been fit tested to you. Residents living with cognitive impairment or dementia may be fearful of your appearance. Please announce and identify yourself when coming in the room and provide reassurance. Some staff have even taped photos of themselves to their gowns to remind their residents of who they are. Most facilities set up donning and doffing stations for PPE within the COVID-19 unit. Please use these stations to don and doff. Do not put your PPE on in the room. It should be put on before you enter the room, and PPE should be doffed when you leave. Your mask should remain on at all times. If you have not been shown the proper techniques of putting on and taking off personal protective equipment, please ask your supervisor for further instruction. These are 2 videos given by the CDC on how to don PPE or put it on, and doff PPE, take it off. You can pull out your cell phone and use your camera app to scan these QR codes to review these videos in depth. An important part of infection control and prevention is hand washing. Hand hygiene should be always used with soap and water or hand sanitizer with at least 60% alcohol. In addition to washing your hands before and after eating, touching your eyes, nose, and mouth, touching your mask, entering and leaving the resident's room, or touching any frequently touched surfaces like door handles, telephones, or countertops, you should always wash your hands or use hand sanitizer before and after putting on PPE and taking it off. Please ensure your residents' hands are washed too. They may need assistance in this. How long should a resident be in isolation? Guidelines are most up to date on the CDC website, but currently a resident should be in isolation for 10 days and have no remaining symptoms, and should also have a temperature of less than 99 degrees for at least 24 hours without using medications like Tylenol or ibuprofen to suppress an elevated temperature. Immunosuppressed residents, like those on certain immunosuppressed medications, may have to be in isolation longer because the virus may be active in their bodies longer, and so isolation for immunosuppressed residents should be up to 21 days. Treatment for COVID-19 is multifactorial. The mainstay of it is supportive care. Dehydration happens very quickly in older adults with COVID-19. Please ensure to push oral fluids like Gatorades, juices, and water. If they're not able to take fluids by mouth, consider escalating your concerns to the care team, and they can consider IV fluids. It's important, especially in residents living with cognitive impairment, to consider the question, would the resident pull out an IV? You know the resident best. Your input is critical. You should discuss that with their care team. Encourage oral intake. Often lack of smell and taste due to COVID-19 suppresses the appetite, as well as symptoms like sore throat, nausea, and just general malaise and fatigue. Oral intake may likely decrease in COVID-19, so offer the residents' favorite foods, give finger foods, and minimize distractions. Residents during this time that used to be able to self-feed may require one-on-one feeding assistance, so please evaluate for that. Other medications that are used in the treatment of COVID-19 are acetaminophen or Tylenol. Certain oral antiviral medications, if available, may be prescribed by the medical care team. And monoclonal antibody infusions vary based on availability within specific facilities, and also vary based on effectiveness with different COVID-19 variants, but you may see this used as well. Other higher level medications may be used in a hospitalized setting or with a patient who has severe oxygen requirements. Monitoring is incredibly important in residents who have COVID-19. Older adults with COVID-19 tend to get sick very quickly, and so should require more frequent vital sign checks to anticipate this. Consider checking vital signs every 4 hours and include a temperature, a heart rate, blood pressure, and oxygen status with these vital checks. The physician, nurse practitioner, or physician's assistants will likely check labs more frequently in these individuals to monitor things like kidney function, electrolyte levels, and track things for developing bacterial infections or dehydration. Consider transferring the resident to the hospital for low oxygen levels that are not responding to use of oxygen through a nasal cannula, or for other concerns that the care team has. Please align transfer to the hospital within the resident and their family members' goals of care. Other common infections and medical problems that we know are related to COVID-19 include COVID pneumonia, which is a viral pneumonia, but secondary bacterial pneumonia, which requires antibiotics, can develop after a COVID pneumonia. Blood clots or deep vein thromboses are common in COVID-19. Dehydration, delirium, which is that confusion we had discussed, and depression is very common during and after a COVID-19 infection. Prevention for COVID-19 is very important. Vaccination is the #1 prevention measure for COVID-19, and residents and staff should pursue vaccination to make sure we're as protected as possible. Screening, both with testing and symptom evaluation, can help prevent COVID-19 infection spread. Care cohorting, as we discussed, where the same staff work with the same residents in the same facilities, can help limit spread. Personal protective equipment and hand washing are so important for prevention. Please wear your mask and wash your hands. Some questions you might have regarding the special population of those living in assisted and skilled nursing facilities are, what should I do if a resident won't keep a mask on? This is a great question, and it's a hard answer. Those living with cognitive impairment, they may not keep their mask on. A lot of reminding and redirecting is important, and you can do your best. Another question, what if my resident keeps trying to come out of his room, especially the COVID unit? Redirection, again, reorientation, higher staffing ratios on the COVID unit may help assist with this. Keeping a physical barrier from the COVID unit to the rest of the facility can also help prevent wandering within the facility. What should we do about new admissions to the facility, especially new admissions where there's not prior testing coming into the facility? Consider a 10-day quarantine period for these individuals. Consider requesting testing before and after admission. You can have new admissions put on a designated area or unit in the facility until their quarantine period is over. This should not be in the COVID unit. We should not mix unknown or COVID negative individuals with known COVID positive individuals. Thank you so much for listening to our presentation. We hope you enjoyed it.